Good afternoon, everyone. I'm going to get started. I'm Sandy Hassink. I'm going to touch today on insulin resistance, type 2 diabetes, and NASH. I have a lot of information in these slides because I want you to have it. I will take questions if at the end or at the middle. Just raise your hands. I want to make this fairly informal. This was one of our patients. She was 9 years old. And this is her glucose tolerance test at age 9. Okay? So the question is, how does a 9-year-old get type 2 diabetes? Right? This is, of course, when I went to medical school, we didn't even think anybody, that wasn't an adult could get this. So I want to spend a little time on this and then on some of the diabetes recommendations and then some time on NASH. So mom was overweight, dad was overweight. She was a large baby. Suspected maternal gestational diabetes. The mom had recently been diagnosed with type 2, unspecified early feeding difficulties. So we know that there's a genetic predisposition, there's an intrauterine predisposition. We know that obese moms have an increased risk of gestational diabetes. And diabetes, and this alters the intrauterine environment and produces babies that are then going to be more at risk for obesity and diabetes. So infants born to diabetic mothers have increased adiposity in childhood. They have an increased risk of obesity, impaired glucose tolerance, and type 2. They may have the exposure to less well-controlled diabetes in pregnancy may lead to an altered insulin receptor expression and insulin sensitivity. There is some data that show infants that are small for gestational age may have an increased prevalence of obesity, and they may be in this state of having a nutritional, environmental mismatch to what they were programmed for in intrauterine life. So suffice it to say that the intrauterine environment is becoming increasingly important, and many of these changes are thought to be mediated by epigenetic changes. So these are the changes that are induced by environment and methylation groups and histone acetylation groups, and they hook onto the DNA and they actually modify readout. And if that wasn't scary enough, because now you're programmed for later in life events, that these methylation changes and epigenetic changes can be transgenerational. So I think as we are improving the environment, we have more and more women who have had childhood obesity attaining reproductive age, we have intrauterine environments that are increasing risk. So in preschool, she was still at a high BMI. Mom's response to bringing her in, and she had episodic care, unfortunately, not sure that the child can ever lose weight because the whole family is overweight. She eats because food is there. She sneaks food. Grandma can't say no. So you have a sort of a behavioral phenotype here that is not unfamiliar to most of us, and so and that was at preschool. And then I wanted to talk about, so in this condition of this preschool child, who do we test for type 2? If you wait till they get symptomatic, you're going to miss a lot of impaired glucose tolerance, and you're going to and early diabetes. So the current criteria are overweight. If you're overweight, and you have 2 of the following risk factors, which many of my patients have: family history of type 2 and a first or second degree relative, race or ethnicity, Native American, African American, Latino, Asian American, Pacific Islander, any sign of insulin resistance, PCOS, Acanthosis Nigricans, hypertension, SGA, maternal history of diabetes or gestational diabetes. The current testing recommendation is 10 years or at onset of puberty. You know that insulin resistance increases during puberty physiologically and often will tip somebody into diabetes or impaired glucose tolerance. So we have these recommendations. We test, and we'll talk about what to do to test for diabetes, but these are the current recommendations. Test every 3 years. If you take care of any amount of obese children, most of them have at least 2 risk factors for diabetes. Just by age 6, we did a 2-hour glucose tolerance test, and you can see there that you saw her at 9. This was at 6. She had a 2-hour glucose of 133, slightly high insulins. At that time, her hemoglobin A1C was 6. She had acanthosis. She had her HDL was low, her LFTs were normal. So you have a situation of insulin resistance. There's some issues about the 2-hour glucose tolerance test because although we use 75 grams of glucose, some people feel that that's not reflective of what a binging child or an overeating child will take in, which may be why her hemoglobin A1C looks like that. You know acanthosis, we see it at the neck creases, under the arms, in the umbilicus, in the groin area. You can see it over the knuckles. Goes away when the kids get metabolically better. And it's kind of a neat thing that the parent can watch. And it's an external sign if you're getting better or worse. It's a little less obvious in your Caucasian children. But you look for it, you see it oftentimes. Many parents come in and don't know what this is, have tried to scrub it off. It's a talking point you can use, and they can watch it, and you can talk. It's associated with insulin resistance. When you're thinking about prediabetes, and so we're all thinking about prediabetes because we prefer to get these kids before they get actual type 2. Why? Because if you have impaired glucose tolerance, as I talked about this morning, the pathway toward type 2 seems to be very fast. So the classification of the American Diabetes Association is a fasting blood sugar of 100 to 125, or a 2-hour value of 140 to 199, or an A1C of 5.7 to 6.4. And we're going to talk a little bit at length about the hemoglobin A1C, since that has now been brought into the mix as a tool for potential use for screening and for diagnosis of diabetes. There are some issues to think about. The 2-hour oral glucose tolerance tests are not always reproducible. Insulin resistance varies, and over time, even in the same kid. And so out of this very small group with impaired glucose tolerance on the first oral glucose tolerance test, 3 of these had it on the second. And percent agreement was very low. Fasting blood sugar may be more reproducible, elevations in fasting blood sugar, but that's a later sign. That can be a later sign where insulin resistance may be up and not varying. The discordant blood glucoses were more insulin resistant. And so we don't have great ways of testing, and I just point that out because we're feeling compelled to test, and I just want to highlight that it's not always as accurate as we would like. However, we are using the term prediabetes. It's a diagnostic code. It's indicating high future risk, and the feeling is these are not clinical entities in their own right, but rather elevated risk factors. And you know the associations with obesity, dyslipidemia, hypertriglyceridemia, high cholesterol, and hypertension. But I think at this point, if we wait for them to become type 2, it's hard to get them back from that once the beta cells have failed. The risk is sort of curvilinear, so that as the A1C rises, the risk of diabetes rises disproportionately. So at the higher A1Cs, like 6.3, 6.4, we're in the 6s, your risk is elevated. 7.5 is the diagnosis of diabetes. And why screen? Because we want to intensify our efforts. And so this is really intensification of lifestyle efforts. So in our clinic, we're trying to catch these kids on their way up toward diabetes and intensify the lifestyle as much as we can, yeah.
Sometimes kids like this come back with a 5.8, 5.9.
Yeah.
And they're otherwise okay. They don't have the dyslipidemia.
Yeah.
And all the rest. You just check them how often?
I think it depends on what they're doing. So if they're back and they're meeting their goals and they look pretty good, I'll wait, 3 months, 4 months, 6 months. If they're gaining rapid weight, the test really, the hemoglobin A1C is really set up for a 2 to 3 month measure. I will confess that I test more frequently if I'm worried. So if a kid's escalating, like you have, an 18-pound weight gain in 6 weeks, yeah, I'm going to track it. And some of that's for me and to tell mom, and I'll be honest with that. But it really is set up to be a 2 to 3 month test. Much of our data about prevention, can you prevent this trajectory from occurring, is from the adult literature. So adults who are pre-diabetic, moderate weight loss, regular activity, dietary strategies, fiber, limited intake of beverages, prevented or delayed the onset of type 2. So much of our data about can we even prevent this once it starts comes from adults, but I think that it's sort of a call to action to us to say, at least in the adult situation, we can slow progression. This is self-evident, and these A, B, and E are levels of evidence that this is based on. This is but follow-up counseling is important. This is a chronic disease, and there's something that seems to happen, at least in my kids that I see, when you have both obesity and prediabetes or diabetes, it seems like the energy that we need to put into that system to create changes even more than just plain obesity. They call for coverage, and if you do code for prediabetes, at least in my world, I get covered. The adults use metformin in the pre-diabetic stage. We haven't exactly gotten there with kids yet. Metformin is reserved now in kids with PCOS, but we haven't been using it in the pre-diabetic stage. We're still pushing lifestyle. But these are the adult guidelines, and I show them to you because they're more robust than what we have in kids. Randomized controlled trials have shown that you can decrease rate of onset. Now, in a kid, you wonder because we have 70 years maybe in some of these kids. But our mantra to the parents is I can't prevent this possibly, but I'm trying to delay the onset of type 2 for as long as I possibly can. And so in Finland, they showed that 34% reduction of onset of diabetes at 10 years and that it was cost effective. Yeah. We have not. We follow them frequently. We haven't really done that. On occasion, if there's a strong family history and they're used to blood sugar monitoring, we'll do it, but not as a routine. But we will frequently monitor in clinic. So I don't think there's necessarily anything wrong. It just requires some teaching, and honestly, it's sort of a resource issue because we have the nurse has to go in and explain, about it, teach it. And so we've been pushing on lifestyle. It's not a bad idea to do if they'll do it.
Most of my patients don't come in fasting. You get blood tests the day they come in?
That's why I like the hemoglobin A1C and the non-HDL cholesterol can be both done non-fasting. I get fasting labs if I can for new patients. When they come back, that's why I'm capturing the hemoglobin A1C more often than not because I can get it and right there in clinic. 5-year incidence, at least in adults, of a hemoglobin A1C between 5.5 and 6, which is not all that high, is 9 to 25%. I think that's a high rate when you're looking at a young kid. And baseline A1C has been a strong predictor. We'll talk about some of the downside of doing an A1C, but I think as an outpatient clinical test on a non-fasting person, you can do this in your office. You can get paid for the procedure and the finger stick. It might be something to consider if you have a high-risk population. What happens? What do we know about progression in adolescents? At 2 years, out of 117 obese children and adolescents, 28% at baseline had impaired glucose tolerance. Out of that group, 24% of that group developed type 2. 30% remained with impaired glucose tolerance. 45% reverted to normal. And best predictors were persistent weight gain, as you'd suspect, severity, high BMI relative with type 2, and other insulin resistance risk factors. So they do progress. And at 2 years, to have somebody progress from prediabetes to diabetes is pretty fast, just pretty fast. Studies in adolescents, you can increase your insulin sensitivity with diet and exercise-induced weight loss. So this is our drug, right? Diet and exercise. And we can move the dial, and we do occasionally move the dial. Exercise is very, very powerful here and is a good talking point for parents about we do talk about insulin sensitivity and what exercise does and what diet can do. When we find a pre-diabetic kid, we treat them at, we focus on sugared beverages, we focus on calories, we focus on exercise, we treat them, as early diabetics. Exercise data, the specific exercise intervention changes from study to study because I'm not sure that we have the hard and fast prevention recommendations for type 2, but it usually involves some combination of aerobic, and people are now using some resistance training in the mix. Suffice it to say, I think exercise here is being used as a therapeutic tool. There are individual differences in physiologic changes with exercise. So you can exercise, 4 kids the same and get 4 different results in increase in fitness. So you have to understand that you have to tailor this to the kid, and some kids will be slower to gain results from exercise than others. And baseline fitness is dependent on genetics and lifestyle, and baseline fitness differs from patient to patient. So, but I think this is where we really roll into using exercise therapeutically and prescribing it in that manner to the patients. Now, how do we get that done? We have a trainer who works with the kids on home programs. We're working with the Y to build some community capacity because these kids have to work maybe at a very low level and have to start sequentially, and not all exercise programs are prepared to deal with them. So then when we get to diagnosing diabetes, this is an A1C over 6.5, a fasting blood sugar of 126 or more, a 2-hour or a random sugar of over 200, and any patient with classic symptoms, so you know that. So A1C now is rolled into our diagnostic armamentarium, and we have had cases, we have kids walking into weight management clinic who, when we do their first hemoglobin A1C, they're already diabetic, previously undiagnosed. So it's not all that unusual for us. And this is alarming because these kids have been in our healthcare system for quite a while. So how much of what to do? I'm trying to get hemoglobin A1C machines into our primary care offices. Actually, the business people buy it more than the primary care people. Our business office says, sure, because you can bill for it. You can bill for the stick. You'll pay off your machine. Getting it worked into the primary care workflow is just, who's going to do it training. But it's a point of care testing, and it's actually not that hard to do, and we do it all the time, yeah.
One of the things that's impressive is how long it took for the hemoglobin A1C part in children.
There wasn't.
I wondered, in fact, to tell you the truth, I started using it several years ago.
I've been using it for about 7 years.
And even way before.
Yeah.
Just curious
Yeah.
why it took so long.
The endocrinologists, I think, from my discussion with my own endocrinologist, case of 1, there's been a lot of resistance, and I am still not sure why. Now, this costs more than a glucose. So there is a cost argument, but there has been a lot more resistance than I would have suspected because in type 1, they use this all the time. And we'll see some of the confounders of this, but I think we're at a place where I feel like if you're dealing with a high-risk population, that you're really worried about getting this early and intervening, that this is a test that you might want to consider more than we have. So the incidence of diabetes, as far as people kind of can know now, it's very high in Native Americans, African Americans, Asian Pacific Islanders, and it's higher the older you get, Hispanics. So these are your risk groups. And you know that in Southeast Asians, they get type 2 at lower BMIs. It's the visceral fat, and they're at very high risk for type 2. So in 2009, relatively recently, the American Diabetes Association or the International Expert Committee recommended that they use hemoglobin A1C. The ADA only adopted the criteria 2 years ago. And then with a lot of qualifications, you have to use a standard method, and you have to use proficiency training for point of care. But I think you can overcome these barriers, so your lab can help you at your hospital. There are some caveats. An A1C cut point over 6.5 identifies fewer cases than a fasting glucose cut point of 126. So it's somewhat lower sensitivity at the designated cut point, but it may be offset by greater practicality and wider application. And of course, we're not, as obesity folks interested in obesity, I'm interested in when you get diabetes, but I'm interested in identifying you before you get your diabetes. So I'm interested in how I can intervene and prevent this from happening. So I think, there are downsides, but I'm interested in the hemoglobin A1Cs from 5.8 and up. There is a similar relationship between A1C and the retinopathy as in fasting plasma glucose in 2 hours, and this is what pushed them to accept it. That the relationship was the same for the endpoint complications. So what are the advantages? Greater convenience, greater pre-analytical stability, and less day-to-day perturbation, since it's a 2-month measure, which for an outpatient doc like me makes all the sense in the world. The disadvantage, and I checked this out with the lab, it does cost more, and the cost is the reagents. The reagents you need to do a hemoglobin A1C cost more than the reagents you need to do glucose. That's the cost. So we have to just understand that. However, I will tell you again, when we look at the business case for this, I have not had pushback on the business case. It's a billable diagnostic test. In the developing world, there's not so much availability. And in certain people, we'll talk about those certain people, there's a limited correlation of hemoglobin A1C with glucose. It may vary with race and ethnicity, and match for fasting plasma glucose. African Americans with and without diabetes had higher A1Cs. It might be that they have a higher glycemic burden, but there is that slight difference. But this is adults. There's no studies in children about these differences in ethnic. This is an interesting one because abnormal hemoglobins will affect the hemoglobin A1C. And if you have bleeding, and so 2 weeks ago I saw an adolescent who had PCOS and had abnormal prolonged bleeding, and I got her to our adolescent doc, and we also did her fasting blood work, and her hemoglobin A1C was 3.7 because she was bleeding so excessively. So if you have a lower than expected hemoglobin A1C in an adolescent who has PCOS, you might not get, and they're not giving you that history, they might be bleeding. So how do we confirm a diagnostic test? You need another confirmatory test, usually of the same test. So if the A1C is 7 and the repeat is 6.8, the diagnosis is confirmed. If 2 different tests are used and they're both above the diagnostic threshold, you confirm the diagnosis. And if 2 different tests are available and they have different results, you repeat the highest test. So that's just where you are with that. We know this, but I just wanted to give you this. At the time of diagnosis of type 2, metformin is the drug of choice with the caveats of measuring liver enzymes and watching out for lactic acidosis. If they're markedly symptomatic, insulin therapy would be started. And that's pretty much where we are. We are not waiting. Nobody is waiting on this diagnosis. And we take our type 2 diabetics until they go on insulin. We follow them, and we follow them in obesity clinic just because we can see them. We're committed to seeing them more often. So medical nutritional therapy, you can get the A1C down, and you can sustain the improvement as long as you're working with the nutrition and they're following nutritional guidelines. Nutritional therapy works, and in the big diabetes studies, nutrition and lifestyle therapy work better than metformin. 1-year results of intensive lifestyle show an average that you need about 8% weight loss. Significantly reduces your A1C, not so different than we knew before. And exercise. And I can't overstate the importance of exercise in prediabetes and diabetes. The higher the level of intensity and the greater increases in fitness, and the higher you get the insulin sensitivity, the better this works. So let me just pull out this slide. So follow-up treatment, diet, exercise, and metformin. If they're successful, you continue. If it failed, you add insulin or a second agent. This is usually when you get to the endocrinologist for us after they go on metformin. And they're not succeeding. And what we're finding is that what you really want is good education for the adolescent with type 2. and at the very beginning. And so the endocrinologists have not always extended their educational model to cover this large group of type 2 patients like they do in juvenile diabetes. So we're still working on capacity for that one. Goal of treatment, like you would suspect in any chronic disease: physical and psychological well-being, weight loss, long-term glycemic control, control of the comorbidities, with family involvement, and nutrition and education and pharmacologic management as your touch points. I won't spend a lot of time on these. I'll put them in your slide deck so you have them. Low carbohydrate diet. So if you refer them to endocrinology and they want a carb count, what you have to be careful is you need a low caloric diet, hypocaloric diet to induce weight loss. So carb counting came because you're trying to match the type 1's insulin requirement to their diet. And a type 2, you need weight loss. You need weight loss. You need weight loss. And sometimes the type 1 people are focused on carb counting without, it's okay, but you set a lower calorie standard to push to. Because if you don't get weight loss, you don't get any help here. So this is just metformin in patients with, this is adults, but we are not, at least we are, and I'd be interested if any of you are, we're not currently treating children with prediabetes or impaired glucose tolerance with metformin. The data isn't that good to say that it's better than lifestyle right now. We are treating them once they get to be diabetic. So if we have a lot of emotional need to do things for these pre-diabetics, but we're trying to follow the data. If metformin is contraindicated, or if you failed metformin, you consider insulin. These are the contraindications to metformin, and that this is when they go to the diagnosis. 6 to 8 years after diagnosis in adults, you get beta cell failure. We think it's maybe happening a little quicker in kids. Again, scary stuff. And then bariatric surgery. In adults, this is being used for the treatment of type 2, especially if they're comorbidities. We haven't yet got there with kids. We're still using weight and comorbidity criteria. Type 2 is one comorbidity, but we haven't, and I don't know if we will, and I don't know if we should get there for treatment of type 2. And of course, it's only a treatment if the weight goes down. But there is some suggestion that the gastric peptides have an influence on this, and there may be some independent effect of surgery. So when we look at just the obesity insulin resistance spectrum, we just talked about type 2. We'll spend a little time on NASH, but these are the other outcomes of insulin resistance in this population. Polycystic ovarian syndrome, very common. Remember that your girls with premature adrenarche are going to get PCOS. So you need to follow them and not let them go. So a little girl with premature adrenarche and then doesn't get her period, or has delayed onset of menses, may have PCOS, and that's why she's not getting her period. So you do have to follow them. These are the classic symptoms of polycystic ovarian syndrome: hyperandrogenemia, oligoamenorrhea, hirsutism, acne. We don't really do ultrasounds if they're obese and they have insulin resistance and hyperandrogenemia and oligoamenorrhea, they get put on birth control pills or metformin, and that differs depending on your consultant. The endocrinologists tend to use metformin. The adolescent doctor tends to put them right on birth control to break the cycle. I wanted to spend a few minutes on NASH. The diagnosis here, many children have fat in their livers. If you look hard enough, they also have fat in their pancreases, and they have fat in the muscles, and that's why we think they're insulin resistant. This diagnosis, you start making it when you have elevated liver enzymes. Obesity and type 2 are the strongest predictors for the progression of fibrosis, which is really the problem. Fat in your liver is a metabolic disruptor. Fibrosis can lead to cirrhosis and liver transplant. So that's the scary part of this disease. And we'll talk a minute about the etiology. And family members, children with family members with liver disease seem to be at much higher risk, and we think there's a genetic predisposition here. So predictors of elevated ALT in obese children look like they're going to be male gender, Hispanic ethnicity, elevated BMI and insulin resistance, but you can't tell from looking which kids are going to have NASH and which kids aren't unless you measure their liver enzymes and ultimately biopsy them, which is the ultimate diagnostic test. Predictors of fibrosis are obesity, insulin resistance, and maybe leptin. And the other thing that you now have a liver at risk, and you have liver toxins in the environment. So you have alcohol, you have other liver toxic medications. And so cautions here to parents who have, if you have a fatty liver, this liver is more likely to be damaged by these toxins. School-based study of kids with ALTs over 40, 23% of older teenagers. In an autopsy study where they biopsied livers, the prevalence of, in Jeff Swimmer's pediatric population, the prevalence of non-alcoholic fatty liver disease was about 10%. Obesity, older age, and you know those risk factors. So it's in this population, it's been hard to tease out without measuring the labs. You do see when you look on biopsies, hepatocellular injury, lobular inflammation, perisinusoidal fibrosis, all the classic signs. And there's a unique pattern of more macrovesicular fat. And so somewhere I'll show you a biopsy of one of my patients. But this is the theory. You have obesity, you have a fatty liver, maybe some genetic predisposition. There may be an environmental factor at work here, sets up a cycle of inflammation. Your inflammatory cells come in, you start to get fibrosis, and then you may progress to cirrhosis. This is the more complex picture of this in terms of just the factors that are thought to contribute to fatty liver and progression of fibrosis. And we don't have any good fibrotic markers. If we did, we would be measuring them in serum. People are toying with that, but the only real way to tell if your liver has fibrosis is to biopsy it. And this is a liver biopsy of a 10-year-old patient. Okay, you can see the fat in the hepatocytes. You can see the bridging fibrosis and the portal fibrosis here. And she went on to develop cirrhosis. So this is a 10-year-old liver that, you know, I'm sort of speechless because this is nothing we ever thought we'd see in kids with just obesity as the etiology of this. So treatment, the only known treatment is weight loss. So finding out about this early, you have maybe some chance to ameliorate it. People have looked at vitamin E. There's some studies that suggest that that might help. People are desperately looking for a drug for this, but we don't have one yet. So loss of 10% of weight normalized for ALT and AST. What we don't know is can we get rid of the fibrosis once it occurs? And in adults, only half the patients who have fibrosis as adults in their liver who lose weight, only half of those patients have cure of the fibrosis. Half of them remain with some fibrosis in their livers. The primary outcome, they just did a tonic study, and they used vitamin E and metformin, and it's suggested that vitamin E might be helpful, but confirmatory studies are needed because of the way the data worked out. And metformin administered at least at 500 milligrams twice a day had no effect on any of the liver histology. So I will just stop there. This is just to basically alert us that the epidemic, behind the epidemic is coming, and it's type 2, and although not every obese kid will get type 2, enough of them will get type 2 that it's going to strain our resources and the resources of the adults, and that the liver disease is sort of the occult part of this epidemic, and I don't even know that we have a good handle on where we are with that, and how many of those kids, because you can't do serial biopsies. No IRB so far has been able to approve serial biopsies in these kids, so we don't really have a good handle on the progression or the risk to progression, or how many of the pool actually have the cirrhosis of unknown etiology as young adults that come to transplant, but we know some do.